Hello, everyone, and thank you for having me. I'm Latonya Fore, certified bariatric nurse practitioner and obesity weight management specialist at University Hospitals of Cleveland. And today we'll discuss customized approaches to using weight loss medications after bariatric surgery. I have nothing to disclose. Our objectives for this presentation are identify which patients would be appropriate for anti-obesity medications after weight loss surgery, understand when to initiate anti-obesity medications for patients after weight loss surgery, and then utilize case examples to demonstrate customized approaches to using anti-obesity medications in a bariatric surgery setting. Obesity, as defined by the Obesity Medicine Association, is a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health problems. And we'll keep this in mind when we are considering adding anti obesity medications to patients in a bariatric surgery setting. As Dr. John Scott discussed in his presentation, is weight regain a spectrum and when do we intervene? We've learned that weight regain is an issue for many of our patients after weight loss surgery. As you know, there are several factors to consider when the patient is either regaining weight after a weight loss procedure or has lost an inadequate amount of weight. A thorough assessment is required in determining what the cause of the weight regain or inadequate weight loss is. Oftentimes, we find it's dietary related. Perhaps the patient is or has increased their intake of carbs, eating more fatty foods. Sometimes it's procedural related in terms of pouch dilation or an issue with the anastomosis. It could be medically related, caused by medications that promote weight gain, or psychological. And so, as we begin to consider anti obesity medications after weight loss surgery, a detailed assessment into the causes of weight gain is needed. These questions are appropriate to ask and important to ask when determining which patients could benefit from pharmacotherapy. And so, looking at some of the medications that can contribute to weight regain or weight gain, even in patients after weight loss surgery, as you can see, there are quite a few, and it's important to make a note of these when we are doing our assessment. In the spectrum of weight loss treatment options, pharmacotherapy is indicated for patients with a BMI greater than 27 with a weight related medical condition or 30 without. FDA approved options for the treatment of overweight and obesity work primarily by decreasing the appetite, with the exception of orlistat, which blocks the absorption of fat. And so, how do we use this information in treating the patient after bariatric surgery? And so, now that we know that number one, obesity is a chronic disease, two, there's a potential to regain weight after weight loss surgery, and that the reasons for weight regain can be numerous, we have more treatment available with pharmacotherapy. We can offer anti obesity medications and maybe even proactively treat the patient before they actually start regaining weight. So we can add medications as an adjunct to weight loss procedures. We can consider combination therapy of anti obesity medications. And then lastly, maybe even consider some off label prescribing to help with decreasing body weight. And so let's use our case example here, looking at our patient for using weight loss medications as an adjunct to a weight loss procedure, the intragastric balloon. So RJ, he's a 47-year-old male. He's 1 month post intragastric balloon removal, has a BMI of 37, started with a weight of 265 pounds, thus far has lost about 33 pounds. He comes in the office frustrated because he is no longer losing any weight over the past month, despite attempts to follow a low carb nutrition plan. He's reporting that it's taking him more food to feel full, and so his portion sizes are increasing. He's also starting to have cravings for carbs. He hasn't taken anti-obesity medications in the past. His job is very stressful, only having about 5 hours of sleep at night. And he's decreased his exercise due to increased work obligations. In terms of past medical history, is significant for hypertension and depression. His labs are noting there. Want to point out his hemoglobin A1C being 5.8%. No known drug allergies, and medications include 10 milligrams of lisinopril and a multivitamin. And so our impression with our patient here, RJ, is that he's only lost about half of the amount of weight expected with the intragastric balloon. Typically, you see about 25% or so. He should have lost about 60 pounds. He's only lost a little over 30. He's reported an increase in his portions, cravings for carbs. His stress could be also interfering with his inability to lose weight, along with his inadequate sleep. And he's also decreased his exercise. And so we want to use a stepwise approach in determining which medication could be appropriate for our patient here. First, looking at safety, then considering the weight related complications or comorbidities, then the cost of the medication, side effects, and then lastly, duration. And so, when considering safety and determining which medication is going to be appropriate for the patient, we want to do a very thorough assessment and evaluation. So, first, looking at the medical, family, and social history, considering the patient's support systems, nutrition and physical activity history, during a physical exam, looking at the vital signs, with special attention to the blood pressure and heart rate, doing any lab and diagnostic testing, and then finally looking at his medications that he's taking that could potentially be promoting weight gain or promoting weight loss. And then in determining which medication as it compares to the patient history, we want to look at the major contraindications associated with each FDA approved drug. So, for instance, phentermine, you want to avoid in those with uncontrolled hypertension, orlistat, those who have issues with absorption, the phentermine and topiramate, avoiding in women of childbearing age or making sure that she's on 2 forms of birth control, the naltrexone bupropion combination, avoiding in those who use opioids for chronic pain management, and then the 3 milligram liraglutide, avoiding in patients with a personal or familial history of thyroid cancer, particularly the medullary thyroid cancer or multiple endocrine neoplasia, and then with a history of pancreatitis. Utilizing evidence-based guidelines like the preferred weight loss medication guide here by the American Association of Clinical Endocrinologists can also help us in determining which medications are preferred, which should be used with caution, and then which ones should be avoided altogether. When considering the cost of the medications, it can range anywhere from $20 to $1,500 per month. We know there's no coverage for anti-obesity medications for those with Medicare or Medicaid. There is some coverage by private health plans, but this is employer based, and the individual or employer must opt into the anti obesity rider on the health plan. And then as we compare coverage, between pharmacotherapy and bariatric surgery across the country, you can see that coverage for pharmacotherapy is very limited. You and the patient should also consider the adverse effects associated with each of the medication. So for phentermine, there is a potential for insomnia, maybe even some constipation. So working with the patient and determining how to prevent this or minimize the effects is going to be helpful. So taking phentermine, for instance, first thing in the morning, increasing the fluid intake, having a fiber supplement. For the phentermine to pyramate combination, a common side effect is the peripheral neuropathy, which typically goes away in the first 2 weeks. For the naltrexone bupropion combination, patients may have some nausea for the first 2 weeks as they're adjusting to the medication. 3 milligrams of the liraglutide, the patients can also have some nausea. And so I advise patients to maybe even consider taking the drug at night before they go to bed. And then with orlistat, a common side effect is oily stools. So to prevent this, the patient should avoid eating foods high in fat. And so back to our case example with RJ, considering his medical history and his issues, we decided to go with the liraglutide, considering safety first. He has hypertension, but it is controlled. There's no history to indicate contraindications of that thyroid cancer or pancreatitis. He has prediabetes, which is not being managed by any particular medication. In terms of cost of the drug, he knows he has coverage by his health plan. For eating behaviors or expected responses, he's reporting that his initial feelings of fullness post meals are diminishing. We also educate him on some behavioral modification, looking at improving his sleep, reducing his stress, increasing his physical activity, and maximizing his nutrition plan by assessing his protein intake, having him keep a food journal. So, combination of anti-obesity medications. It is logical and it could help us in potentially improving the weight loss outcomes with our patients because they do target different pathways. But as providers, you should know combinations of FDA approved weight loss medications should only be used in a manner approved by the FDA, and that there are currently no long term studies of weight loss drugs in non FDA approved combinations. So back to our patient, he returns for follow up, still having food cravings, but his overall appetite is improving with the liraglutide. He's kept a food journal over the past few weeks here. Noticed that he had been eating quite a bit of fast food. He's having issues with remembering to give himself the injection in the evening. And he has started to increase his exercise with walking in the middle of the afternoon, also increasing his sleep. So again, using our stepwise approach, starting with safety. And so now we want to start to dive a little deeper into how each of the medications work and the expected response of each drug. So we know the liraglutide, 3 milligrams, works in decreasing the appetite, but because it is a GLP-1 and for the most part works to delay gastric emptying, the patients report a decrease in portion sizes. But what else can we add to help this patient in helping him meet his goals? So the naltrexone bupropion combination could help with reducing some cravings, some emotional eating. The phentermine to pyramate combination could also help with cravings for food, especially with carbs. And then the orlistat could help with decreasing fat intake because of the side effect of oily stews. And so our updated treatment plan for this patient is we're going to continue the liraglutide because it is helping. And we counsel the patient on maybe anchoring it to something he already does in the evening, say brushing his teeth. Maybe before or after he brushes his teeth, he gives himself the injection. And then maybe we start bupropion on naltrexone for his food cravings, also noting he has a comorbid condition of depression. So that combination may help him. In terms of off-label prescribing, here's a list of medications typically used off-label to help with weight loss. As you can see, it's pieces of other drugs that are already FDA approved for obesity treatment. And we do have some research to support off-label prescribing. In a study done looking at 172 patients after bypass and sleeve, it was noted that those who took anti-obesity medications, over 54% lost at least 5% of their total body weight with anti-obesity medications after weight loss surgery. And it was shown that actually the medication topiramate was the most effective, at least in that study. And so in terms of management, follow-up is key. It helps with keeping the patient on track, and it helps you assess as a provider how the medications are helping. So the patient comes in, if not in a month, maybe even in 2 weeks, and then once a month for the first 3 months, and then maybe extend the visits every 3 months. And so when do we consider discontinuing the medications? When the patient reaches a BMI of 27 or even a BMI of 25? Do we consider after there has been an improvement in weight-related complications? And so I always tell the patients in preparing to stop the medications, if they want to stop the medications, number one, obesity is a chronic disease. There's no cure. It is going to require long-term treatment. But if you are considering stopping the medications, have we optimized your lifestyle? So do you have an eating plan you can stick with? Have you and are you getting the 300 minutes recommended, if not more, of exercise per week? Do you have a strategy for slip-ups, holidays, environmental stimulus? So if you go to work and it's National Donut Day, what do you do? How do you manage being tempted by those types of foods? And then are you or do you have a plan to self-monitor your food intake and your weight? But even with that in mind, once stopping the medications, there is a potential for weight regain. Each medication, for the most part, has a recommendation as to when the response should be evaluated. Normally, at about 12 weeks or so, we should be looking at if the medication is working. Has the patient lost at least 5% of their total body weight? For the liraglutide is 4% at 16 weeks. And so we keep this in mind on follow-up. Are we getting the response that we're looking for in terms of decrease in body weight? And so we want to use a stepwise approach when selecting the medications for patients after weight loss surgery. We want to use the medications in patients with BMIs greater than 27 with comorbidities or 30 without. We manage the patients with frequent follow-up. And then after weight loss surgery, you're assessing on follow-up visits the patient's weight, their dietary habits, and then their symptoms. In summary, obesity is a chronic disease requiring lifelong treatment, and the patients need to understand this after weight loss surgery. The journey is just beginning, and that there is an option for anti-obesity medications. As a provider, you want to take a stepwise approach when selecting a medication. And anti-obesity medications can be used post-surgery. Knowing when weight regain could likely occur, you could even consider proactively offering the anti-obesity medications to the patient. And follow-up is important to long-term success. I want to thank SAGES, University Hospitals of Cleveland, the bariatric surgery team, and Dr. Lena Katon for this opportunity. Thank you.